Alright, so this lecture we're going to put everything kind of together and show you how to evaluate respiratory failure in a critically ill patient using lung ultrasound to help you kind of evaluate what's going on. So remember, a lot of times for hypoxia or hypotensive episodes, you really don't have the time to go through ordering official ultrasounds, and especially for lung ultrasound, there are not a lot of acute things that you can order. So let's say you have the clinical case, patient presents respiratory rate 40, speaking partial sentences, saturating 78%, confused, what do you do? Remember, you'll always do your ACLS and ABCs. Once you have that under control, you can actually use ultrasound to kind of help you guide what could be going on. I typically use ultrasound, lung ultrasound in the acutely hypoxic patient in a couple of scenarios. When I have just recently placed someone on non-invasive ventilation and I'm trying to figure out which cause is the predominant cause. A lot of times these patients have almost every condition you can think of. You know, they're not taking their Coumadin, they have COPD, they have heart failure, and they're coming in with respiratory failure, and you're trying to identify which of the following components is affecting the patient the most. And this is where I use ultrasound to kind of help me out. Also, I use it when I've had to endotracheally intubate someone for respiratory failure. After I get the patient stabilized and improved oxygenation, I immediately do the ultrasound. So remember, most of our etiologies are hypoxic and hypercapnic, and so our ultrasounds are kind of focused to evaluate those. So our learning objectives is you're gonna use all the signs that we've talked about so far, found in lung ultrasound, and evaluate respiratory failure in an algorithm. There are a couple of them out there, but the most common one is called the Blue protocol, and we're going to talk about that. So the Blue protocol was originally written in CHEST in 2008. It's a compilation of about 18 years of research. It kind of allows you to give therapeutic options while you're organizing your overall plan. And we all know that physical exam and radiography are not always as precise. I just use ultrasound as an extra tool to help out identifying what could be going on. So this is the algorithm that he kind of created. And we're going to go through each one of these steps for the different type of lung processes. And eventually, after you get good with it, just like your advanced echocardiogram and advanced shock algorithms, you probably will be using some form of this, but you may not be using the exact type. Just to show you, at the bottom here, you see this decision tree does not aim at providing a diagnosis. It indicates a way of reaching a 90.5 accuracy when using lung ultrasound. Meaning, when he studied this in the article, that during the initial admission, he was actually 90% right with the final diagnosis based on using this algorithm. So just an introduction to the Blue protocol. This CHEST article showed that the original doctors that admitted these patients were wrong 26% of the time, and actually inappropriate therapy was done about 10% of the time. This was an observational study in teaching hospitals. It was performed on admission, peak of dyspnea, serially on patients with respiratory failure, and the final diagnosis that they used was the final diagnosis that the ICU team made, who did not take into account ultrasound data. What are the typical diagnoses that we saw? Well, it's typical spread of what you would think you would see. Pulmonary edema, pneumonia, COPD and asthma kind of together, and a very small components of PE and pneumothorax causing the respiratory failure. This table in the article just showed that if you break down the profiles that he used, which we're going to talk about in a second, you can see that there is a distribution of certain profiles with certain disease processes. For instance, if you look at pulmonary edema, 62 of them had a B profile, which we'll talk about. If you look at COPD or asthma, 75 of them had a normal profile. So we're going to go through those. This slide just shows you that there's most of the disease processes we're looking at here has really high sensitivity and specificities, with pneumonia and some of these having 100% specificities. Go back and refer to the regular lectures that we have given on pneumonia, pneumothorax, and cardiogenic pulmonary edema to help solidify your process on this. So after years of lung terminology, the analysis came up with 3 items. First, you need to decide if there's lung sliding present or absent. Second, you need to identify if there are B lines at the anterior wall, present or absent. And third, you need to look at the posterior and or mid-axillary regions to look for pleural effusions, pneumonias. And you can actually do an added adapted venous analysis, which is a DVT ultrasound, which can be indicated in 54% of the cases that were done in this study. So if you did find a DVT, then in the appropriate respiratory failure patient, you may consider that pulmonary embolism is the cause. Just a quick review for pleural effusion. Remember, pleural effusions in the posterior and or axillary region will show up as a positive quad sign in which you have fluid between a lung, the chest wall, and the 2 rib shadows. For pneumonia, you're looking for shred signs, tissue-like signs with air bronchograms inside. Here's a picture of some linear and punctate air bronchograms. And here's an image of a pneumonia with dynamic air bronchograms. And again, these are all in the individual lectures also. So let's go to profiles. So essentially, what we develop as we develop this algorithm is we call patients into profiles. If you see an A profile, that means that you have A lines everywhere in all lung fields evaluated, in the anterior and lateral regions. We're not talking about posterior yet, this is just anterior and lateral. If you have a B profile, you have B lines that are sliding in both lung fields, all anterior and lateral lung fields. If you have an AB profile, you have A lines on one side and B lines on another side. So just remember that for now. So let's go through the first one. So if you have an A prime profile, when you see the symbol prime in this context, it means without lung sliding. So if you have an A profile without lung sliding on a particular side, and actually a lung point, that indicates a pneumothorax. If you don't have a lung point, you actually have to look at other diagnoses, such as pulmonary fibrosis. Sometimes you can even have ARDS and a few other things without B lines, or the patient is apneic or mainstem intubated. Refer to the pneumothorax lecture for that. But just as a summary, here's a pneumothorax with a lung point, where you see absence of lung sliding on this side, and you see positive lung sliding on this side. The next thing I want to go through is an A profile with lung sliding. Then you have to look at if you have A lines everywhere, then the next thing you should do is go to the back and in the posterior region and look for pneumonias, and look for DVT in the lower extremities. If you see a DVT in the lower extremity with A lines everywhere, and the patient is hypoxic and in respiratory failure, remember I'm talking about respiratory failure patients who are on non-invasive ventilation or recently intubated, then pulmonary embolism may be the cause. Refer back to the DVT lecture that has been performed to see how to adequately do that. If you have a pneumonia, then you have a pneumonia as the cause. So the next thing we're going to look at is if you have A profile without PLAPS, which means you have A profile everywhere. You have it in the anterior, the lateral, and the posterior regions, and you had to intubate this patient for hypoxic arrest. Actually, sometimes you even see very prominent A lines. You see more A lines than normal. The bronchi is surrounded by air, are inaccessible to current non-invasive ultrasound. So in this case, you will think that COPD or asthma is the cause of the patient's respiratory failure. This is a picture of someone who has what I would say prominent A lines. You can actually see A lines more prominent than normal. We've talked about this, but if you have B profile, that's bilateral anterior predominant B lines with lung sliding, that indicates pulmonary edema. Now remember, without lung sliding, having a B profile can indicate ARDS or pulmonary fibrosis. It has to be a bilateral process. Remember, the B line is a thickened interlobular septum, And again, refer back to the pulmonary edema lecture. This is the B profile with the pulmonary edema. That's actually one of the easiest ones to do, so I kind of do that one first. So a B profile without lung sliding, again, if it was unilateral, would be pneumonia. The inflammatory adherences are due to exudate, generates acute pleural symphysis, and frequent in massive pneumonia and ARDS. You could have bilateral, but mostly unilateral is pneumonia, and bilateral is ARDS. So again, in this algorithm, you actually see pneumonia in a few different areas. You see it with A profiles, you see it with AB profile, and you see it with B profiles. So pneumonia can be a very tricky thing because pneumonias are different in type. We didn't talk a lot about AB profile or C profile, but just so you know, if you see A's on one side and B's on the others, especially B's without lung sliding, that should indicate to you early pneumonia or aspiration. Obviously, if you go to the posterior region and you see consolidated lung with dynamic air bronchograms, that would also indicate pneumonia to you. So remember, pneumonia can be a lot of different ones, and it's a little bit more complicated. And this is because pneumonia can be all different. Now, does this cover everything? You can still have a lot of rare stuff. For instance, you can have hemodynamic pulmonary edema from drugs, myocarditis, infectious pneumonia. You can have exacerbation of chronic interstitial disease. You can have massive pleural effusions. We didn't talk about anything about pleural effusion in this algorithm, but massive ones can cause acute respiratory failure. You can have fat embolisms, pericardial effusions, tracheal stenosis, and you can also have hypovolemia, acute gastric dilation. I see that on codes on the floor frequently. Usually these will all yield a normal profile. But remember, these will still have the same signs. For instance, the cocaine neurogenic pulmonary edema will still have pulmonary edema, and you should still take all this into clinical context. But you will cover about 95% of the causes if these are all really rare. So just as an example, you would apply the probe to the right upper blue point, you would identify A lines, you would identify lung sliding, you would analyze the space below the pleural line, then you would scan to make sure you're not missing any B lines, then you would analyze the blue point or lower or PLAPS points, and all this should take about 1 minute on both sides and should inform you of pneumonias, pneumothorax, pleural effusions, and most alveolar consolidations and pulmonary edemas. So remember, you're going to use the signs that you found in all the other type of lung ultrasound lectures, and you're going to use it in an algorithm to kind of help you figure out what the causes of the acute respiratory failure. And one of the main important points that I like to tell people is to remember to do this only in the severely hypoxic patients. If you try to do this on someone who is just on 2-liter nasal cannula and in the emergency department, it doesn't really work that well. The time to find some of these lung artifacts have not happened. And so only do this in the severely hypoxic or non-invasive ventilation, or if you recently endotracheally intubated somebody for respiratory failure. All right, that's it.